Janelle Ali-Dinar has more than 15 years of senior healthcare executive experience. She is the Vice President of Population Health, Rural Health, and Global Health Initiatives at MyGenetics. That's easy. A nationally advanced precision medicine organization that specializes in the care solutions for rural, minority, tribal, veterans, and public health. Dr. Ali-Dinar has served in the positions of CEO, COO, Vice President, and Regional Director of Strategy, Operations, Rural Health, Leadership Development, Physician Engagement, and Urban, Rural, and Global Healthcare for some of the nation's largest healthcare systems. She often is featured as a keynote speaker on Capitol Hill and at national conferences. Her other roles have included the National Rural Health Association Fellow, Rural Congress member, the Nebraska Rural Health Association President. Dr. Ali-Dinar currently serves as chair of the Nebraska Department of Health and Human Services, Office of the Minority Health Statewide Council, and co-chair of the RHEC 7 Partnership Committee. She also has been appointed to the Nebraska DHHS Preventative Health Service Committee, the National RAC Monitor Editorial Board, and the Midwest Public Health Training Center, Center on Diabetes, and National Education Advisor Committee. Dr. Ali-Dinar holds both master's and doctorate degrees in communications. She also is a recent graduate of the Public Health Leadership Program. Please join me in welcoming Dr. Ali-Dinar.
Well, hello everyone. I'm just going to say a quick disclaimer. I do not have the little hedgehogs or puppies, but we have plenty of dynamic models to talk about today, which I hope will invigorate and stimulate some of the grand work that you're already doing and prep up for some of the great work that needs to be done in 2018 and moving forward. So, I want to thank you all because while your job descriptions might say rural health or public health or population health or even health care, you all work the entire spectrum. So if you work in health care, you work in population health and public health. If you work in public health, you work in health care and you work in population health. The point is, a couple of years ago, we were still trying to figure out what role does public health play in health care and population health. And with the increase of immunizations, influenza, the cost of care, and the increase in chronic diseases, especially diabetes, there is an exceptional role that public health plays in all of these dynamics. So I want to thank you for adding on to your job descriptions today. We're going to talk about models of care, but I want you on this journey to think about it from this context. So I'm going to give you the definition from FORHP, which is the Regional Health Equity Council, which is part of the National Action Partnership. And it's a simple definition, but it is also so hard to achieve. And it's one statement. Health equity is the attainment of the highest level of health. And if you think about it, we're really only as healthy as the least healthiest person. And when you think about it from that standpoint, you suddenly recognize that when we talk about diabetes and how it's becoming part of an epidemic proportion, you start to think about that it is going to be a lot more difficult time to raise the bar to the least healthiest so that we can truly achieve health equity. So now on with the show. So, key takeaways for today. So these are the things I'm going to tell you, and we're going to talk about it, and then you'll be able to have some key takeaways of Toolkit information with you so that you can begin to really unbundle it and figure out what's important to my work today as you talk about your state strategic plans, as you talk about all your upcoming plans, whether it be diabetes related or another chronic disease. the nice thing about these is that there's so many moving parts that there really is something for everyone, no matter what facet of work that you work in. So we're going to talk about the facts, the risks, the statistics, and the realities, and some of that has already been covered. We're going to talk about caring for populations during change, and we are in the midst of transformative change. We're going to talk about optimizing margins and population health growth, and some bonus opportunities and value drivers that you may not be aware that exist. We're going to talk about top diabetes innovation care models across the nation. And mind you, these have been established as some of the most highly recognized, but truly, right now, there are at least 150 different models that are out there. And so this is not to not recognize the tremendous amount of work that's already being done out there, unsung heroes and heroines. And you'll have some links to also take a look at some of those. And then 5 and 6 are toolkit of additional models of care and toolkits of reference resource information. So some of what's already covered is the talking about where the US population is going, who has already been diagnosed, those who are undiagnosed. But it's also important to remember our children, because our children today are facing diabetes, they're facing disproportionate high levels of obesity, and we also know that part of these chronic diseases go hand in hand. But when we peel the layer back even more, we find that our multicultural communities, which are our sisters and brothers who are in our communities, whether they be rural or urban, those are even more disproportionate in size. When we look at American Indians, Alaskan Natives, they have a 14.9, and women are even slightly higher. And part of it also is even more from a regional standpoint. When we look at non-Hispanic blacks, 12.7. When we look at non-Hispanic whites, 7.4. Asians, 8%. When we look at Mexican, part of the Hispanic culture, 13.8. Puerto Ricans, 12. Cubans, 9. And South Americans, 8.5. So when we also talk about some who have been here for long periods of time, those who are also refugees for one reason or another, those also have a high proportion of diabetes. When we look at 18 years and older, again, you see that those are continuing to grow, especially in the Asian population. Now, let's talk about some of the risk factors. We have overweight and obesity. We have poor diet, older age, family history and genetics, which we'll also talk about a little later, race and ethnicity, historical trauma, and that is particularly so when we talk about refugees, but more importantly when we talk about our Native American Indians and our tribal nations. Natural disasters and other stressful circumstances, behavioral choices, smoking, lack of physical activity, hypertension, high cholesterol, and high blood glucose. Now, when we talk about our social determinants of health, and part of this also, you'll have some handouts, I believe they're on the right side of your packet. There's one about social determinants of health. And so, sometimes we think about, well, just the social fabrics of our community, but it really does go much deeper than that. We're talking about not just gender and race and ethnicity, we're talking about cultural barriers, which include language, values, religious beliefs. We're talking about marital status, social support systems, economics, economic status. We're talking about health insurance and access to that. We're also talking about food deserts. We're talking about depression, fatalism. And so it's an entire structure that we really have to unbundle, divide, and conquer when we talk about health equity and social determinants of health, when we deliver our care models in diabetes and any other type of patient-centered care. So when we look across the world in this particular slide, we see that there's already, while an ocean might divide us, what we have in common is that we have some epidemic proportions of diabetes. And when you look at how the population shift began to change even in the United States, when you look down at the bottom comparatively from 2015 to 2040, that might not seem like that's that much. You've gone down one individual. But when you compact that total population and what that means to the cost care system, and knowing that most likely diabetes is not the only thing that that particular patient or individual is struggling from, you recognize that that number is really much larger than what that graphic shows. I think the two key points on this one that hasn't been discussed yet is the one that says 1 in $3 and the 1 in $5. 1 in every $3 of Medicare spend today is attributed toward the cost of care toward diabetes. $1 in 5 is the cost to manage diabetes across the spectrum. So when we talk about these models, those are part of the things that they're trying to grapple with and to try to change, is bending that cost curve and recognizing that that is part of what we need to control. Now, the state of diabetes in terms of mandates and insurance exchange, I think, is an interesting one, especially as we talk about how healthcare reform is in question. We talk about where the insurance exchanges have been. And then when we even talk about Nebraska and Iowa, I know from being in Nebraska how we've gone down by 6 carriers down to 1, and we no longer have the cooperatives we once did, and we didn't have Medicaid expansion either. So all of those impact our coverage and how we begin to attack, if you will, and strategize around the elimination or management of diabetes. Let's take one more snapshot at the global emergency and look down at the bottom. And these are actually the numbers. The 1 in 11 and the 1 in 10 maybe didn't mean as much, but when you look at 2015, 415 million people were diagnosed with diabetes. And then look at it at 2040, that's 642 million. There's something in terms of a role that each of us has to play. I'd like to say that it's unacceptable. So why is sustainability and innovation now on the healthcare stage? Now more than ever before, as I'd already previously mentioned, we have more at risk. And let's take just for instance the Affordable Care Act, not knowing where it stands with healthcare reform moving forward, policy reform and cuts, state insurance exchanges and premium increases, moving from fee to service to fee for value is tremendous, and that will continue to be very much an ongoing conversation as we adapt to that new fee structure. Models of care shaping policy and reimbursement, Medicare and Medicaid numbers, public health, the role of pharmaceuticals, 340B programs, regulatory policies, rural hospital closures and access to care barriers, issues of workforce and recruitment, and the needs that we have facing us as we face a 30,000 shortage of primary care providers just within the next 5 years, and 1 million nurses in the next 20 years. And the need for comprehensive services to care for our chronically ill patients. So managing populations of change mean not just that patient in front of us, but all these things that are happening behind the scenes. Means not only meeting the triple aim, it means the quadruple aim, which is also part of compliance and quality. It means population health, creating a culture of health, meeting your diverse population needs, creating access And that might even include technologies such as telehealth or mHealth. Challenging and creating equal opportunities of innovation and creating a competitive edge. So, healthcare innovation. What we are talking about now, some of them began in 2015, they're demonstrating results in 2017, and some of them are just newly birthed and are showing some successes already in 2017. So the innovation selections that we're going to talk about today are based on, and this is kind of the criteria in which they were chosen: access, delivery, outreach, and impact, comprehensive patient care focuses, their uniqueness, and they're being very futuristic in a very realistic world. They're policy focused, focusing on fee for value, and some of them demonstrating reimbursements in other ways, bending the cost curve, quality, and creating patient-healthy outcomes, utilization of technology, creating an environment of increased physician and patient engagement and outcomes. They can be used and duplicated with other models and across the nation. So the first one we're going to take a look at is Project 1. It's a chronic care management. The next one is Living Well. The third one is CPC Plus, or Comprehensive Care Plus. Project 4 is La Vida. Project 5 is ECHO. Project 6 is One Community Wellness. The next one is Precision Personalized Medicine, and then the two toolkits that I had noted. So before we get started, let's take a mental picture, if you will, of the CDC hot map and take a look at, while yes, I know you're in Iowa, I'm from Nebraska, when you look at the fact that we don't have as much deep red, for a moment it makes us feel pretty good. But that also means that much like the weather, these patterns can change, and they can also have high influences. And so while you see that there is a lot of red in the south, and you see a lot of it even in the East Coast and more centralized in the Ohio area down to Florida over to Texas, we do have patches of red. And we do have some that when they are orange, they can easily become red. So as we take a look at these models, keep in your mind this map. So Project 1 is chronic care management, which is known as CCM and complex CCM, and it is still yet more of a physician fee schedule. It focuses on diabetes, annual wellness exams, obesity counseling, depression screening, smoking cessation, imaging, cardio testing, sleep studies, in-office testing labs, renal care, as well as the addition of precision medicine. And I know some people have said, well, I do a little bit of that. But the fact is that you're probably not recognizing that there is a model dedicated to that where you could be optimizing a much higher reimbursement than what you would otherwise think. You know, a primary care physician might give a foot exam, but say, but that's just part of my care. But if you use the right CPC codes, you can actually have a much, much higher reimbursement. So these are some easy wins, if you will, as you try to look at building not only your patient care and your outcomes and the management of the diseases, but also operationally looking at your financial margins to also increase your wellness. So the value add drivers, and I'm not sure why that's not popping up, but for instance, if you were to take a look at the state of Iowa and you were to incorporate all of those aforementioned services, the average rural health clinic would easily increase their bottom line by at least $200,000. Now, $200,000 just to get started is not a bad opportunity to want to maximize, recognizing that the more often you do it, the increase of how that margin continues to propel itself. Same thing in other larger settings. There is a fee structure, and when we talk about some of these other models of care, some of those physicians or clinicians who are part of an ACO, they definitely want to be optimizing these opportunities. and now it pops up. So a quick example is even just in one clinic, even in another part of a region, it was an addition of about 200,000, and that happens to be in a state where there are several rural hospitals closing, and it makes all the difference to keep them open based on what their clinics are doing. All right, so Project 2 is Living Well program. And I don't know if you are optimizing that in Iowa or not. We just began that actually a few months ago in Nebraska. It's a program that's sponsored by Stanford University. And again, it not only takes a snapshot look at diabetes, but it includes all the other chronic diseases to manage. It is a 6-session interactive workshop, and it teaches, as we begin to go more into fee for value and take a look at patient accountability, some of these models, such as this one, try to help increase accountability by the patient standpoint to gain a better control of their health. The results of the program are creating less fatigue and increasing more energy, better health, more active lifestyles, and less time in the hospital, which reduces readmission penalties. Managing medications, which is huge to the forefront of healthcare right now. Eating well and accomplishing goals, reducing stress, and learning how to manage your life a little bit better. There are 2 opportunities on those links. Next project is Comprehensive Care Plus. This is a program that actually began in 2015. It just rolled out in its 2nd year. This is a CMS program. It is Nationally Advanced Primary Care, and it is to strengthen primary care, and it has now been awarded in Louisiana, Nebraska, North Dakota, and New York. Now you might be thinking, okay, so if it's not something that's open for me to apply for, why is it important? Fact is that there was so much of a favorable result in the outcome measurements that this is now program year 2. It will be back open probably beginning sometime in 2018. So I'm foreshadowing what is happening out there and getting you all to think, because Iowa is innovative, that this might be a model that you as a state might want to participate in. The first round are the insurance payers who have to supply an RFI for their intent to participate. And then the second round, once it's awarded, are then the primary care providers and specialists who can sign up for that. So in Nebraska, for instance, Blue Cross is the payer, but it is a statewide initiative, and it's one of those that can bring not only a lot of margin and economic sustainability, but it's one of those to demonstrate better patient-centered care in a more comprehensive model. This map is actually where it's located nationally in both programs 1, and that helped actually evolve into the whole need for it to be moving into the 2nd year. So far it's 54 aligned payers, 14 regions in round 1. There are 7 payer structures for CPTC round 2. And these are partnership practices that increase both flexibility in the care and they increase financial resources. It is not only to achieve the triple aim, but the quadruple aim. So far, it supports in round 1, 2,850 primary care practices, which are 13,000 clinicians, serving over 1 million Medicare beneficiaries. And what's key to this is that this is focusing on your Medicare beneficiaries. The focus areas are access and continuity, care management, comprehensive care coordination, patient and caregiver engagement, and planned care and population health. So there's a care management fee, there is a performance incentive payment that's given, and there is a payment under the Medicare physician fee schedule. So if we really had to boil this down, point is that you're managing your patient's care. You're seeing them anyway. Why wouldn't you want to give them the full spectrum benefit of the care delivery services that are out there? And oh, by the way, why wouldn't you want to optimize that for yourself and create the best type of management program for your patients? So there's a support number, and I've listed that twice because I've been asked about, where can I contact? So you've got it twice there. Again, as well as the link, and that is a CMS innovation model. Again, it will probably come back open again in the spring. So check those out. Give yourself a good early running start to see if that's something that you wouldn't want to adapt to. Also, we have to begin thinking about conditioning our insurance companies, and so as you talk about them and work with them on your diabetes initiatives, you need to get them kind of warmed up to this as well. The next one is the Levita Lifestyles and Values Impact. Now, some of these models focus on our community health workers, which are any of you community health workers? If not, it's something that you might consider having within your programs. They are your professional liaisons in the community to help manage some of the community work and patients that otherwise you wouldn't have. And so they're the extra eyes, the extra ears, the extra hands that your primary care physicians need. So this particular program is in New Mexico. It's Hidalgo Medical Services, and it focuses from a holistic standpoint, mind, body, and spirit. They have 30 different services, and if any of you have ever been to New Mexico, you have a mountainous region. And sometimes when we talk about in rural health access barriers, it's one thing to have to drive from critical access hospital 30 miles to receive your services, but it's quite another thing when you actually have a mountainous region, much like the Appalachia, that actually serves as a barrier of care. But they've been able to work through the barriers, cut through the topography, and find that relationships really do work. So they began this in the year 2000 through a public awareness campaign, their PSAs, and they began thinking about if we were to create a holistic approach, how might we bring to the table primary care and specialists and utilize telehealth and community health workers. Their goals were to create advocacy, get to the homes, help them with their buying and shopping and thinking differently about their groceries, creating one-on-one sessions, and creating cooking classes. They also recognized that the patient is the family. So long before patient-centered care and thinking about extended families really became part of our traditional buzzwords, they were already doing it. And their results have been that 55% follow healthy eating, and if any of you have habits like myself, you know it takes a while to break these habits and to create and shift the paradigm of our thoughts and behaviors. So it's extraordinary that they've got to the 55% mark. 90% with their HbA1c levels are checked by a physician, and 44% engage in exercise at least 5 days a week, and that's the entire family. So that really is a very impressive. That is a CDC funding Reach Us program, so I would encourage you to also check out the CDC websites to also take a look at funding opportunities that exist. The next one is Project 5. It too is in New Mexico. It is the ECHO program, and it stands for Expanding Capacity of Health Outcomes. Now that is traditionally a telehealth model, and that has helped immensely for the rest of the United States to really garner attention on the benefits of the usage of telehealth. It was founded in 2003 by Dr. Arora, and he is the professor of internal medicine at the University of New Mexico. They started out with the idea of what was their most chronic focused disease, and at that time it was hepatitis C, so it was really around the treatment of that. Through that, they developed the discovery program, if you will, how diabetes was growing rapidly in their populations. And so it quickly grew to what is now called the Diabetes and Disease Management Program. They have more than 6,000 patients enrolled, and much like the previous model, they've had to work through the elimination of mountainous regions, desert regions, to reach the access of their patients. And today, that particular ECHO program has now spun off to create nearly the same size programs to treat mental health, to treat substance abuse and opioid abuse, gestational diabetes, inflammation diseases, and then for diabetes and obesity. And the link to that particular model, if you'd like to learn more, is also included. This particular model, as I mentioned, has also created not just how we think about, especially when we talk about rural delivery of care, the usage and the benefits of telehealth, but it's also driving where legislation is. Telehealth has not been as widely used by primary care specialists simply because there hasn't been a sustainable or sometimes recognized reimbursement for that care delivery. So the ecosystem is really pushing that because they've had now several years to demonstrate the success of that. For those of you that like to read thousands of pages of political bureaucracy that's out there, it is known as HR 5395, and should that be passed, and there's no reason why it wouldn't be passed, you would see that what's happening in New Mexico, just by virtue of telehealth, would help you in Iowa be able to reach access in your diabetes models and how you help your patients. So Proiect ECHO also wants to focus on duplicating models for behavioral health, recognizing that not just hepatitis C and not just diabetes are important, but also how we address mental health. They also have a third model, and that's to address the opioid epidemic and pain management addiction across the U.S. So focuses, as I mentioned, are opioid addiction, also the increase of autism, HIV, women's health, suicide prevention, and it's rapidly expanding into these states, Nevada, Montana, North Dakota, and throughout the VA system. So there are several grants that are also out there. Rural health policy is one particular one that takes very much a close look at telehealth and the ECHO expansion program. So Project 6 is One Community Wellness, and you see a little icon over there. That is their mobile bus that they use. Now, much like I described in New Mexico, where you have the topography of the mountainous region, any of you who have ever been to Central Appalachia, you recognize not only do you have the mountains, but you also have an infrastructure of more challenge in their roads and their bridges as well. So a few other challenges and dynamics. But this particular program are mobile health clinics that provide free health care to 11 rural Virginia communities. It is called the Health Wagon. It provides comprehensive health care. They actually provide CPC Plus on wheels. So I would highly suspect that they would be one of them that would say, we're demonstrating really good results. Why wouldn't we want to apply for the CPC Plus model? And right now, just in its first couple of years, that's gone from 400 families to 4,000 families. So imagine what kind of gas mileage and time management that little mobile has got to have, as well as those helping hands who deliver that service. They wanted to, in their intervention, what was key to them was to eliminate access barriers, increase communication and engagement and accountability, as well as to lower the cost of care because they were actually delivering home health, if you will, in another type of way. So they're achieving the triple aim and the quadruple aim in a very innovative way of going out with a mobile unit. And the grant funding and funding sources can be shown on Health Wagon, CDC, Rural Health Policy, and CMS Innovation are the ones that are grant supporters for those particular type of models. Now I'm going to have some deep affinity for this one because this happens to be my own employer, and I'd like to say best for last is actually in a way quite true, because what's fascinating about that is that when we talk about population health from a precision management standpoint is really per patient health, and it is how you drill down to the precision care of each individual person. Or as I like to say from a rural standpoint, since I grew up in rural Nebraska, rural is my roots, rural is my passion. We're comfortable in our genes, let's get comfortable with our genes. So we know that diabetes, those people have an elevated risk for heart attacks or strokes by 500%. And of the 30.3 million people diagnosed with diabetes, 65% of them will suffer a heart attack or a stroke during their lifetime. That's not to scare. There's plenty of things to be doing out here to prevent that. Several of the other speakers, myself included, would endorse there's lots of things that we can do to lower that long before it ever arrives at that point. The point is, in precision medicine, is to be tested from a very unique standpoint. So of the 65 and older with diabetes, 7 out of 10 will die with heart disease, 1 out of 6 will die of a stroke. That's not my employer saying that, that's the CDC saying that. So knowing your patient's heptoglobin genotype can help you determine if you carry the high-risk variant. And at the back table, there's some literature that really spells that out quite well. We've developed a proprietary type of solution that's called MyHap2. And what it is it's not like 23andMe, finding out if you're Swedish or you're German. It's taking a saliva test and running that test through several different genotypes and finding out from a polypharmacy standpoint, where am I in my pre-stage of any disease? And we'll use diabetes as an example, but it could be cancer, it could be COPD, it could be psychiatric. But a snapshot in time, unlike blood lab work, which can change, your genes are not going to change. So you take a once in a lifetime saliva test. We run that across the spectrum of polypharmacy, and we can tell you, are you a fast metabolizer, slow metabolizer, no metabolizer of a type of medication? So in the management of diabetes, where there's so many different types of medications that are out there, and I'll use my own parent as example, she's been on so many different types of medications for diabetes that while that's her only chronic disease, medications don't make you feel very well. And where you have a growing older population with diabetes and even a younger population that's on the increase, risk stratification says that we should focus on the ones who are most chronically ill because that's where the payment mechanism is, but truly everyone should do that. Not only is it fascinating, but you really should know what's happening inside your genes. This can tell you what medication you should be on. So the point is you get the right dose at the right time for the right reasons for the right disease. So My Genetics also offers the revolutionary type of HAP2 that I mentioned. And studies indicate that 36% of diabetes carry that very high risk variant. And so what's fascinating about that is that a lot of primary care physicians will say, if you take vitamin E, that's all you need. But if you had a different type of risk variant with, let's say, cardio, and you really were a high risk, meaning I've got a high risk with diabetes, and I got a high risk for a heart attack, then you would take a simple vitamin E. But if you didn't have that, you could actually increase your chances of a CV event because you really don't need vitamin E because your body's not absorbing that. So personalized medicine really offers you an opportunity for disease prevention in a lot of different types of variables. We take a look at your genes, your environments, and your lifestyles. We actually focus on social determinants of health and start to look at the big picture of what that person's care, wellness, and management plan should be from a spectrum of not just genes, but the environment in which they live, and the ethnicity in which they come, and the cultures of which they come from. So think of this as GPS mapping, and as I already said, it's the right dose at the right time for the right diagnosis. And our footprint is in chronic diseases such as diabetes, cardiology, pharmacogenetics, also known as polypharmacy, behavioral health services, and corporate wellness. We utilize Medicare, Medicaid, and private insurance. We're approved in every state. And then we also have several precision medicine initiatives that we have. And we also are currently working with several medical universities and some of the nation's largest healthcare systems. We have some pilot models that we're getting ready to launch in some rural systems. We work with ACOs and partnerships with payer structures as well. We provide testing for heart disease and the correct medication to address obesity. And a huge part of our work is in medication management, and that's why the polypharmacy helps, is that if you have been diagnosed with 2 or more chronic diseases, it helps you understand so that you can get a better grasp on reducing the cost of care, especially in medications, and reducing the cost of care that it would take maybe for an illness that lands into an admissions into the hospital, which could have a cyclical effect of having a readmission. So across the spectrum, as we demonstrate to CMS, this affects every facet of healthcare. So precision medicine, as I mentioned, is about reducing costs for medication, hospitalization, the ER, psych, oncology, and cardio. It enhances the patient experience. It creates better population health. It reduces the cost. And it improves physician experience. So an example of, even in diabetes, with some it's brought down the cost of care by $5,000, some over $25,000. In the case of cardiology, where it's staved off a CV event, it has reduced it by managing that. We've been able to stave off those events, which could have been with a $400 test or a $250,000 hospitalization and surgery. So the benefits for the one-time test are extraordinary. So I talked a little bit about MyHap2, then we also have MyHapGT Live, which again is taking your medications and seeing across the spectrum. If you change the variables of your age, your ethnicity, 10 different dynamics, what that type of medication would mean to you. We're doing a lot of work in the opioid space to reduce unnecessary usage and really look individualized at how pain management should be so that you can reduce the propensity to addictive behaviors, oncology, behavioral health, ER, and cardio, as I'd mentioned before. If you'd like to learn more about my genetics, there's the website for that. There's also a TED Talk on there, and I would encourage each of you. TED Talks can be very entertaining, and even though genes might sound like, what a dry topic, it is actually done and communicated in a fascinating way. And no, I'm not the presenter, it's Dr. Dave Vigorous, but he really unbundles it in layman terms, fascinating. So, here are some other models that I would encourage you to take a look at that have been designated as the top models of care for need, intervention, and results in the areas of diabetes. Some of them utilize community health workers, as I mentioned before. Some of them have also not only adapted diabetes, but they've taken a look at other types of chronic diseases. Some of these are as early as 2017. Some of them are from 2015. They have been financed by the Federal Office of Rural Health Policy. and a Rural Health Services Outreach Grant. So to that, I have two opportunities I want you to think about. One of them is due on Monday. So now that's almost kind of like a professor talking. But this isn't an easy one. I invite you, as you talk about innovation in Iowa, and again, you don't have to hear it. You already know that you're doing a lot of cutting edge things. But we need to help CMS shape their thoughts. And much like political constituency, if you don't talk and give your voice to what is needed in your home states or in your region, someone else will decide for you. And bottom line, someone's going to get the money. Why not it be Iowa? So fill out this very short survey. The address is at the bottom. It's CMMI, New Direction. And there's also the CMS initiatives direction that can give you a snapshot of some of the other innovation models that have been funded. But here's where they're focusing. So the innovation model is interested in testing models in 8 different focus areas. So what you're going to do in this RFI is you're going to think about what is a model of care, or what's something that you're currently doing within your state. So if I were to use Nebraska's example, we have a state health improvement plan. One of our focuses is diabetes and obesity. We've got some initiatives that we might want to get funded. I would take one of those and say, where does that fit in the different areas that they are focusing on? But you'll see it's increased participation in APMs, and we get to talk about that later this afternoon. Consumer-directed care and market-based innovation models. You can see you can read a lot into that. Physician specialty models, again, ambiguous, so kind of create and carve out your own niche. Prescription drug models, Medicare Advantage innovation models, state-based and local innovation, mental and behavioral health, and program integrity. So you have a lot of breadth and depth of creativity that you can put into this. It's very short. It's just round 1. Basically, you're going to submit an idea. The other opportunity is to, as I mentioned before, when there was that list of different models that are out there that have been funded, up to 150 of them by the federal rural health policy, there is a federal grant for rural working with tertiary centers, and rural maybe even working with federally qualified health centers. That deadline is December 6th. It is everything and the kitchen sink. It is a long one, but if you've already got pieces and parts out there from either another grant or an initiative that you've been working on, I would invite you to take a look at the Federal Office of Rural Health Policy, and that one that's due on December 6th is really at the top of the page. Take a look at that, because you've probably already got partners in place for that. This particular page is about additional resources. All of these either have grants that either have been open, are open, or are ones that they continually fund. And then down at the bottom are some other opportunities and relationships that I would invite you to take a look at what they're doing. Regional Health Equity Council, which I talked about before. We do some fascinating work in not only social determinants of health and health equity and cultural class standards. We're also an MOU partner with the Midwest Public Health Training Center with Lori and with Kate. And so we have worked. I just came out of a federal board meeting the last 2 days. These are available. I'll have some if you think it's very intentional to your work, and I'd have to say it's intentional to all of your work. But it takes a look at Iowa and your surrounding sister states. It can tell you how you stack up against them in your areas of work, in how you provide insurance, the demographics and socioeconomics, how the social determinants of health and minority populations or rural populations have been affected. I would say these 2 resources would be great for you when you apply for a grant. You would have some really relevant statistics to use. So the future is all about policy support, funding, grants and reimbursements, training and education, highlighting these successful demonstration models, taking a look at some of them, unbundling them, figuring out what might work for your population, and then collaboration. And if I can't answer your question today, or we don't have that opportunity, please feel free to contact me at any of those numbers. The 615 is our Nashville corporate office. I reside in Nebraska, which is the 402. Or feel free to reach me via My Genetics. I know it looks like gene text, but it is genetics. And I'd love to have a dialogue and help you through if you have any other questions with what's been presented now or what's presented later at our 2 o'clock session. But thank you. And see, you didn't need puppies and hedgehogs. Any questions?
We do have quite a few that are coming in. So the first one, the CPC Plus works with which parts of Medicare? Could you please elaborate?
So it works with all facets of Medicare's, and this next layer will also work with the Medicare Advantage.
All right. And are the providers in the health wagon in the one community wellness program or nursing staff?
What part of nursing staff?
The question that was typed in, and I apologize here, are there providers in the health wagons in the one community wellness program, or are they nursing staff? So are they physicians or
Okay,
nurses?
got it. Okay, so that includes primary care PAs and nurse practitioners.
Perfect. And that is most of the questions we have right now. Does anyone want to pose a question to the mic?
Can I say something?
You're not upset at me that I almost tripped over your feet and walked on them before, right? I'm forgiven already. Go ahead, please.
I want to make an observation. I am Dr. Herco, and I've been involved in diabetes in Iowa for the past 58 years. That's before some of you were even born. So I was working at it a long time ago, and it becomes very frustrating at times. However, there are various things I'd like to point out. How many people in the room are either diabetic or have had a relative either living or dead that's had diabetes? Put your hand up. Hello, there's a lot of you. My mother was a diabetic. I'm a diabetic, but I'm just a little bit, like being a little bit pregnant. I'm a type 2, and I exercise routinely. And one of the treatments for diabetes, especially in type 2s, type 1s you can't do much with. They got it, you can't make it go away. As far as I know, unless they do islet transplants and all that sort of stuff. But the treatment for type 2 diabetes, which is about 90% of all the diabetics, is diet. How many people in the room have ever been on a diet? Put your hand up. Is it fun? I always look at it as D-I-E. Die with a T. Oh, it is terrible. Following a diet is not easy. It is very hard. Especially when people look at you and say, why don't you eat this? Why don't you eat that? It's hard. The other thing along with diet is exercise. I go to the Y 6 days a week, and I've been doing that for 58 years. When I die, I'm going to be in good shape. But when I ask people, what do you do when you get the urge to exercise? Well, I lie down until the urge goes away. No matter what you do, the diabetes is getting worse. And the thing is, what are you going to do about it? They say, well, go on a diet. Does it work? It might work for a while. I've had patients who lose the weight, but how many manage to keep it off? Then they follow the diet, and it usually doesn't work, and the diabetes comes back, you tell them to exercise, and they'll say, okay, fine, they'll exercise, but I don't know how much they'll do. The only thing that I know, and I've been around a hell of a long time, you may use diet, you may use exercise, but it ain't working. Why is diabetes getting worse? Are we doing such a good job that people are living longer? I doubt it. The only thing that I know of, and I just read the literature, hell, I'm getting old. I'm 88. Therefore, I still have my camp for diabetic kids. I've been doing that for 50 years. I've had 15,000 diabetics. I also started the first diabetes outpatient education center in the state of Iowa. That's a long time ago. The only thing that I know of that is working so far is the bariatric gastric surgery. So therefore, I'll leave you with a question. Are we going to take all 90% of the type 2 diabetics and have them have bariatric gastric surgery because it does work, but I don't know for forever? I don't know. God bless you all.
That's some wise, practical wisdom and food for thought. Back on that mobile, there are some mobiles, their spin-off mobiles also are just nurse practitioners. It depends on legislatively what their scope of services can be and where their reimbursements are, scope of care. And some of them have more nurses or they have more PAs. But collaboratively, they've been able to figure that out. And they also work with their sister sites. So it might be a clinic like a critical access hospital that's 25 miles away, but they collaboratively work because they recognize better for them to all be unified and stand together as rural than to be closed.